Perfect. Welcome, everyone. Good evening, and thank you for joining us. Tonight, we have a very special edition of Ask Our Experts. It's the COVID-19 vaccine special edition, and this is organized and hosted in partnership with Dufferin County Canadian Black Association and Wellington, Dufferin Guelph Public Health. A special thank you to Dr. Mrna, Anna, Danny, and the rest of the Wellington, Dufferin Guelph Public Health team for putting the community first and, most importantly, partnering with DCCBA to organize this important info session for our community. For those of you who don't know me, my name is Alethia O'Hara Stephenson, President and founder of the Dufferin County Canadian Black Association, an organization that was established to advocate for and advance the needs of the Black community in Dufferin County. We have a special commitment to advancing the needs of our youth in particular, focusing on youth achievement and excellence. On behalf of the entire board, it is my honor to welcome you all to tonight's episode. Before we introduce our special guests, I'd like to go over some housekeeping items. During the presentation, please keep your microphone muted. You can submit questions at any point during the chat, and we will pick up the questions at around the 7:35 to 7:40 mark. After we've gone through the presentations from both Dr. Tenenbaum and Dr. Khenti, we will have a chance to ask questions live. You can simply use the raise your hand feature, and we will take up your questions then. For any questions that we don't get a chance to answer during tonight's session, rest assured we will collect these questions and make sure that we get them answered for you. The questions will later be posted on DCCBA's website. So thank you everyone for joining us. At this point, I would like to introduce Jordan Stevenson, DCCBA's board member, to introduce Dr. Tenenbaum and Dr. Khenti to us. Jordan?
Thank you, Alethia. Hi, everybody. Hope everyone's doing well. So I'm here to introduce our two experts for the evening. Our first guest is going to be Dr. Matthew Tenenbaum. Dr. Matthew Tenenbaum is the Associate Medical Director of Health for the Wellington, Dufferin Guelph Public Health Unit. In this role, Dr. Tenenbaum provides oversight, support, medical expertise to staff and community partners. Prior to joining public health, Dr. Tenenbaum worked for several years as a family physician in the city of Hamilton. He completed his residency in public health and preventative medicine at McMaster University, during which he spent time at several different health units in Southern Ontario, including the WG Public Health. Dr. Tenenbaum holds a Master of Public Health from the University of Toronto and a medical degree from the McMaster University. Our second guest is going to be Dr. Akwatu Khenti, and he is the Special Advisor for the City of Toronto's Targeted COVID Equity Action Plan and is the chair of the Black Scientist Task Force on Vaccine Equity. Dr. Khenti is an assistant professor with the Dalalana School of Public Health at University of Toronto and an advisor to School on Equity and Inclusion. He is formerly the Assistant Deputy Minister for the Province of Ontario's Anti-Racism Doctorate, as well as CAMH's Director of Transformative Global Health. So without further ado, I'll introduce our first guest, which is Dr. Matthew Tenenbaum. Thank you so much.
Thank you so much, Jordan. Thank you, Alethia, and thank you everyone for making the time this evening. Thank you to the DCCBA for organizing and hosting the session this evening. Hopefully you can hear me. I'm just going to try and share my screen, so please bear with me for one moment, and we'll try and get something for you to see. Okay. Can I just do a quick check, Alethia, that my slide's visible?
Yep, I can see your slides. Perfect.
Perfect. All right. Thank you then, everyone, for being here this evening. So I appreciate you making the time. I know that with COVID-19 having, of course, had a significant impact on our community over the past year and the advent of vaccines on the horizon, there's been a lot of news, a lot of new developments, a lot of information we're sharing, and a lot of questions that you'll likely have about the vaccines, the vaccine rollout, the vaccine science, and what it all means for you and I. And so I do want to make sure we can share some information with you tonight. And I want to make sure that we have a chance to tackle questions you might have about the vaccines, and we'll do our best to answer some questions for you. I will give a bit of background to start things off, and I hope that we can continue the conversation on over the course of the rest of the evening. So I'll begin by just talking a bit about our local vaccine program in Wellington, Dufferin, Guelph Public Health. So locally, we've been delivering vaccines into arms since January. So it's been about 4 months now. And we know that, we've been talking a lot about physical distancing, wearing masks, staying home. All these things have been able to help us manage the pandemic, reduce cases, reduce outbreaks, et cetera. However, now we have vaccines as an extra tool in our arsenal. And vaccines are an important tool. They're going to help us not just manage the pandemic, but bring it to an end. And this is something that's going to be incredibly helpful. However, we can only do that. We can only end the pandemic if we have broad uptake of the vaccines in our community. Vaccines work best when everyone, or almost everyone, is immunized, since that really allows us to break chains of transmission that happen when COVID-19 spreads in our community. And early on in WDG, we knew that it was going to be very important for us to get at least 75% of our eligible adult population immunized in order to begin approaching that goal of really dropping transmission down. Just recently in our area, we crossed the 50% threshold, and we're very pleased to be able to do that. And we're continuing to deliver vaccines fast and furious. And we're aiming to hit our target of 75% of our eligible population by the end of June for first doses. Beyond that, we'll continue to tick up beyond 75, hitting 85, 90 if we can. And we'll also be delivering second doses of vaccine. And we're well on our way to really having a broad and wide uptake of the vaccine in our community. So when you take that figure at 50% and break it down, you can see that the vaccine uptake in our community varies significantly depending on which age groups we're looking at. Early on, the provincial government prioritized vaccine eligibility based predominantly on age. And you'll probably be aware that the first people to receive vaccine across Ontario and in WDG were the older adults living in long-term care and retirement home settings. Given what happened there with outbreaks and the impact it had there, they were the first immunized. We know how vulnerable older adults can be, and that made sense as the first step in our immunization campaign. Throughout the pandemic, age has been an incredibly strong predictor of who's not just likely to become sick from COVID-19, but who's likely to need hospital care, ICU care, and who might die from COVID-19. And so that's been a really important piece in the prioritization efforts across the province. Over the course of our most recent wave of COVID-19, our third wave, we actually saw the impact of immunizing our oldest adults first. We saw that despite the fact that we were dealing with new variants that were more easily transmitted, new variants that caused more severe illness, we saw fewer deaths and fewer cases among our older adults because of the impact that those vaccines had. Of course, as more and more vaccine supplies come in, which is able to happen now, we're able to move down different age groups, and gradually younger age groups have become eligible for the vaccine. So you can see that the younger age groups are playing some catch up in terms of getting the same kinds of coverage as the older age groups. It's not happening overnight and it's going to take some time, but we want to have every single age group above that line of 75%. And if we can get to 100%, we want to get there too. So in Canada right now, we have 4 different vaccines that have all been approved by Health Canada, which you may have heard about. The first 2 are what we call our mRNA vaccines, the Pfizer vaccine and the Mrna vaccine. And those 2 vaccines have accounted for the vast majority of vaccine doses that we've given in our community. These 2 vaccines are also very similar to one another, and they work in the same way. Essentially what they do is they deliver a piece of the genetic code for the COVID-19 virus to your body, and that allows your body to be able to recognize it and to learn how to respond to it if it encounters the real virus out in the community. The vaccines themselves do not cause any infection, and they're incredibly safe. And there's some good clinical data and some good real-world data that speaks to their safety and their effectiveness. Recently, actually, the Pfizer vaccine had its age groups expanded. Now we can give it to people as young as age 12 and above, which is great. That reflects some new data that Health Canada reviewed and some new submissions by the manufacturer. And we anticipate that the age groups that are eligible to receive these vaccines are likely to continue expanding as, again, new trials are done, new data is submitted, and Health Canada goes through their approval process. This is how it usually happens when a vaccine that's new goes into use, because the clinical trials that support a vaccine typically focus first on healthy adults. That's where we have the best data, and then gradually we're able to expand people who we consider eligible to receive the vaccine as we learn from the vaccine's use in the real world. The next 2 vaccines are the so-called viral vector vaccines. Those are the vaccines produced by AstraZeneca as well as Janssen. Janssen is also known as Johnson & Johnson. And these use the same mechanism as each other. They actually use a non-COVID-19 virus that helps to deliver the instructions that your body needs to be able to recognize and respond to COVID-19 and build the immunity that the vaccines provide. These vaccines also don't cause infections. They're also considered very safe, and that's important to know as well. The Janssen vaccine actually has not been used yet in Ontario. It's one that was approved some time ago, but has not been distributed across the province. The Astrozeneca vaccine has been used, in particular in primary care and pharmacies, although you might be aware that recently that vaccine was put on pause in Ontario. That's because of some reports about some pretty rare complications regarding blood clots that are believed to be linked to the vaccine. Now, this rare event is identified because public health units in the province and the federal government, we all play a role in monitoring vaccine safety to make sure that any new or strange side effects or adverse responses are flagged, are investigated, and are identified for management. So this system that we have built up around the vaccines really allows us to find these really rare events that wouldn't otherwise be noticed and allows us to act on them. So these are the 4 vaccines we have in Canada right now, but there are a number of other vaccines that are currently in various phases of development or approval, and they might play a role in the vaccine rollout in the future. All the vaccines that we have in Canada that we've been using are incredibly effective, and that's really an incredible delight given that these are vaccines that were developed so quickly and we didn't know how good they would be when they were developed. This data that you see on the slide here showing these numbers is based on not just data we have from the vaccine clinical trials, but also some real world evidence about how these vaccines have had an impact in real populations when they've been used. We've seen that in some jurisdictions around the world with high vaccine uptake, places like Israel or the United Kingdom. They've actually been able to gradually relax some of the public health measures they've had in place because of the strong protection that the vaccines have provided. No vaccine is 100% effective, even though 95%, for example, is really good. None of these are 100%. However, what we know is that when large numbers of people get a very effective vaccine, that has an incredible impact given the ways it can block transmission from person to person. You can also see that for the 2-dose vaccines, people begin to get protection after they've received their first dose. And I should mention that the last vaccine there, the Janssen vaccine, is a 1-dose vaccine. And we actually begin to see the benefit of these vaccines beginning about 10 to 14 days after someone receives that first dose. The second dose helps provide a bit more protection, get that number up a little bit higher, make the protection last a little bit longer into the future. But both doses provide a huge benefit. And even getting that first dose is much better than having nothing in your system for protection. In our community, there are lots of places you can go to access vaccines within Dufferin County. This includes our mass immunization site at the Alder Recreation Center, and we also have pop-up sites in Shelburne and Grand Valley. All these sites operate on particular days, and you can gather more information about that on our website. And I should mention that when you are able to book a vaccine appointment, when you get your booking code, you can actually pick from any of these sites. We have sites as well outside of Dufferin County. We have mass immunization sites in Fergus and Guelph, for example, and you can pick for any of those. If, for example, you'd rather get an appointment a little bit sooner and you're willing to take the drive and to go to other sites that might have an appointment a few days sooner. So you have the ability to book an appointment at any of the sites within our community once you register and once you get that code for your booking. We are really emphasizing that it's important that when you get your booking code, the most important thing is to get the vaccine as soon as possible. So please, please, please book wherever you can, as soon as you can, and get the earliest spot that's offered to you, because we know that sooner really is better when it comes to getting protection from the vaccines we have on offer. Within WDG, we actually have a pre-registration system on our website. And that's where you can go to sign up to make sure you're in the queue to get a vaccine. Essentially, this allows us to collect your basic contact information so that when you're eligible, we have it and we can immediately contact you to invite you for an appointment. Right now, given where we are in our rollout and given the supply of vaccine that we have, you're likely to get a registration code and a booking invitation very shortly after you pre-register. So if you go online to our website, you enter your contact information, you're probably going to get a code from us within a day or two to have that invitation to book for your appointment. And right now we're saying anyone age 12 and above can pre-register. And that's because we have the eligibility for the Pfizer vaccine going down to as young as age 12. And we should specify that with some of the eligibility, we've talked about the year that you're born being more important than your actual age. However, when it comes to someone who's age 12, you actually do need to be 12 years old on that day. If you're turning 12 later this year, unfortunately, that isn't enough. You have to actually be 12 or older on the day that you book your appointment. So as I mentioned, we've been working to immunize our community in a prioritized fashion, and that's based upon a framework that the province has developed and rolled out. And we're now at a point where we're actually able to offer vaccine appointments to anyone aged 18 and older. Anyone 18 and older in our community can get a vaccine very soon. So if you're 18 or older and you haven't gotten a vaccine, please do go on our website and pre-register. And that's allowing us to get your contact information so that we can reach out to you very quickly with a vaccine appointment. Since we know, as I mentioned, that Pfizer vaccine's able to be given to people as young as age 12, people who are age 12 can still pre-register and still put themselves in the system. And we anticipate that very, very soon we'll be able to offer appointments to those younger ages going down to age 12. Right now, we're really fortunate that even though we have some challenges earlier on with the supply of vaccines, we have lots of doses coming in every week, and we're able to rapidly move through members of our community to get them first doses of vaccine. We want to make sure we're able to offer the vaccine to as many people as possible, so they're getting the broadest uptake as possible in the community and the most impact for our community in terms of protection. Oops. So I should also mention that our clinic sites aren't the only place that you can access the vaccine within WDG. Subject to availability, you may be able to access the vaccine from someone who you feel more comfortable with. For example, your pharmacist or your primary care provider. Some pharmacies and primary care providers are able to offer the Mrna vaccine right now, for example. Pharmacies that are offering the vaccine are all listed on the Ministry of Health website. There are a number of them across our community, both within Dufferin as well as other parts of WDG. And primary care providers, family doctors and others who are offering the vaccine in their offices are right now reaching out to their patients to let them know that they're eligible to get the vaccine. So that's going to be an important part of our vaccine strategy moving forward. And this is another way to access the vaccine that might be better for you. Now, there are a lot of good reasons to get vaccinated. In addition to the excellent protection that a vaccine gives to you personally, it also helps protect those around you because it makes it less likely that you're going to be able to transmit COVID-19 to others. Once lots of us are vaccinated, we can begin to safely relax many of the restrictions that we have in place right now. You might be aware that last week, the federal government unveiled its framework for relaxing public health measures and getting back to a less restrictive future. And those stages we're going to move through as a community are based in part on how many of us are getting their first or second dose of vaccine. The more of us that get vaccinated, the more easily and the more safely we can begin to move through that reopening process. Ontario is currently developing its framework, and we should be hearing more about that in the coming days and weeks. And again, the bottom line is that the more of us get vaccinated, the more of us can get back to our pre-pandemic lives and get back to a more comfortable reality for ourselves and our families and our communities. These are some of the quotes from members of our community when we ask people in our community to tell us what their reasons were for getting vaccinated. These are things people share with us. And again, we all have reasons why getting the vaccine might be a good idea for us. And if you're someone who's thinking about getting the vaccine, it really is worth thinking about what it means for you, how it connects to what's important for you, what it will allow you to do that you can't do right now that matters in your life. And please think about those things. Think about the impact the vaccine will have on you, on your family, on your community when you're making the decision to get vaccinated for yourself. So that's going to end where I have my slides right now. I'm happy to pass the baton back. I just want to thank everyone for your time this evening, and I'm sure there are lots of things we haven't covered, so I'm happy to take your questions later.
Perfect. Thank you, Dr. Tenenbaum. At this point, I'd like to welcome Dr. Khenti. And I know that we have a few questions in the chat. We will get to your questions just after Dr. Khenti has finished his presentation. So please be patient with us, everyone. Thank you.
Okay, so I'm gonna just give a few slides. I won't speak for too long. Most of the key issues have been touched upon. I just want to say that COVID-19 has been a public health disaster for Black communities across North America. We don't have data for every community, because really in Ontario, race-based data gathering has been sporadic, and not every jurisdiction has it. But Toronto is one of those places that have begun to collect race-based data related to COVID. And what we discovered in Toronto was that the hospitalization rate for the 9% of Toronto's population that was Black was approximately 3 times the representation rate, so that almost 3 times as many Black people were in hospital rooms who got COVID as their white peers. We also learned from a StatScan survey 2 months ago, I think, that there's a higher mortality rate among Black Canadians for COVID than their white Canadians, 35 per 100,000 versus 16 per 100,000. And the reason that Black people tend to get more sick from COVID isn't because of any genetic predisposing factors, but because of the underlying conditions related to the social determinants of health and systemic racism. And those underlying conditions aren't surprises to you. Diabetes, high blood pressure, heart disease, asthma, these are common conditions. And what's important about those conditions is that being educated and earning more money isn't necessarily a protective factor for people of African descent living in North America, South America, or Western Europe. So that's really what has made this pandemic double whammy for people of African descent. It's also been a huge economic hit, largely because of job loss. A lot of Black women are in healthcare, particularly women from the Caribbean, from Jamaica, especially from West Africa, Nigeria especially, overrepresented as PSWs, health, nursing aides, those kinds of jobs. And many of them had 2 jobs and 3 jobs, but because of the pandemic, they were restricted to 1 job and very low pay. So they've suffered significant depletion of savings, of wealth. Again, we don't have enough data to really make conclusive, to draw conclusions, but when we look at evictions, when we look at job loss, when we look at insecurity, and we compare the situation to America, we find there's a lot of parallels in terms of impacts. Another big issue that has arisen, not just in Toronto, but in Ottawa and other jurisdictions, is increased mental health challenges. Going into the pandemic, there were many risk factors to begin with due to social isolation and overrepresentation in low income, in the low income sector, because of the increased isolation, because of the increased educational challenges due to online learning. And for people earning below $30,000, $40,000 a year who are not able to work from home, they end up having to leave their children to self-educate effectively. And that's not working for many, and it's causing additional social problems, conduct or behavioral problems are being reported right across Toronto, and I suspect in many other jurisdictions as well. And again, the biggest sort of factor is the social determinants of health, low income, living in a high density neighborhood with not many assets to draw upon in terms of recreational opportunities. So the city has done what it can, from what I heard, so as your jurisdiction to it. We've expanded testing sites, we've translated materials into 30 languages, including many African languages such as Hausa, Somali, several Ethiopian languages. We've been very flexible in terms of taking the vaccines to the community, and created new rules that I could talk about when we get there. But we've also really gone out of our way to provide wraparound supports to people who are in very vulnerable or precarious situations, and who didn't need food security before but need it now, who didn't need mental health wellness checks but need it now. And I think the statistics is already showing that we've sort of buffered the COVID wave in terms of some of the mental health costs. we've been having town halls in Toronto since February 1. And we've had 14 town halls. This is nice. So my slide, this is a dated slide. We've had 14 town halls with about 6,000 people. And what we've been doing is a pre and post evaluations. So like to come to this town hall, we'd have had to answer a couple of questions, and you would answer the same questions going out. And our town hall has usually been 3 hours, and all question driven, no didactic, no lectures, just question driven. And what we found is that at minimum, we had a 16% change in the undecided. The people who came in and self-identified as vaccine hesitant, 16% of them left changing their minds. The 10 or 15 people who came in, 10 to 15% of people who came in and said, I'm not taking the vaccine, most of them left saying they're not taking the vaccine. And I think that's because someone they have to hear it from their doctor, they have to hear it from their wife or their husband or their partner or their family that says you got to take this vaccine, because they're really dead set against taking the vaccine. But we've had positive results. I think the main reason we've had positive results is because the task force is comprised of members of the Black communities. We have people from the Caribbean and various parts of Africa, different languages, different religions represented in the task force. And that representation really has served us very well in grounding us in communities and in allowing us to be perceived as a trusted source, which I think we are. But even though we're about vaccine equity, promoting vaccination uptake, we tell people all the time that the virus is ahead of us right now. The virus is mutating, and we need to be still very vigilant about the use of masks, social distancing, hand washing, all of those practices that we had before but that has gotten a lot of attention, still need to be kept up, because COVID will still be with us. It's going to take us a while to get, for the country, to that 80% herd immunity or 80% vaccinated. And until we get there, we can't afford to relax. That's the message I've been giving at the 14 town halls. 2021, sorry, you got to be geared up. The adrenaline has to keep flowing, because you have to always be vigilant about COVID-19. And with that, let's have that very interesting conversation.
Perfect. Thank you, Dr. Khenti. Those numbers are quite alarming, especially when you factor in the impacts to working moms, working women. It is quite alarming and concerning. So it is definitely a public health crisis, a social crisis. I'm going to jump to a few of the questions that have been posed in the chat. The first question was specifically for, I think, Dr. Tenenbaum. Do medical studies show the Mrna vaccine is safe to give to teens under 18 years old? And why did our health region make the decision to give the Mrna vaccine to 16-year-olds when Health Canada site still says it should be only Pfizer? Of course, this is from a concerned parent.
Thank you, Alethia. And that's a great question to be asking. I mentioned that the approvals for the vaccines were different. And really, when a new vaccine comes onto market, it's based upon the clinical trials that were done. Both the Pfizer and Mrna vaccines, which are very similar to each other, they're both tested in healthy adults, essentially. When Pfizer did its studies, they looked at an adult as being anyone who's age 16 and above. When Mrna did their studies, they looked at an adult as anyone aged 18 and above. So they kind of defined adults differently. And that's why Health Canada said 16 for Pfizer and 18 for Mrna. We know from data that we've had from real-world examples, we know from additional clinical trial data, for example, from Mrna, that this vaccine is actually safe and effective in the younger age groups in ways that are quite similar to the effectiveness in older age groups. So it is safe and effective to give a 16-year-old Mrna, for example, even though that goes beyond what Health Canada has said right now. And as I mentioned, we do expect that age eligibility is going to expand as Health Canada does its approval process and opens it up based upon some of the more recent trial data.
Perfect, thank you. The chat session is now open for anyone who wants to raise your hand, and I'll turn the microphone over to you so you can ask your questions live. Until then, I'll continue with the list of questions that have been submitted so far. The next question is, I am 55 years old. Which vaccine will I get, and what is wrong with the AstraZeneca?
Sure, I'll answer both parts of that question. The first part about which vaccine will you get. Right now in our community, we're getting lots of supply of the Pfizer vaccine, and we're also getting some of the Mrna vaccine. So you're likely to get one of those two vaccines, and we have both vaccines available in the very near future for you to get your vaccine if you haven't already. When it comes to the AstraZeneca vaccine, that is a vaccine that we have been using and recently stopped using. The reason that the province put a pause on that is because of some new data, some new information about a very rare side effect of people getting blood clots after the vaccine. Again, it's a very rare side effect, but it's one that we take very seriously. And it's an important safety consideration, even though it is very rare. Right now, we're at a point where because the supply of the mRNA vaccines, Pfizer and Mrna, is improving, and we're able to offer that vaccine to anyone who wants it very, very, very quickly, the province decided it didn't make sense to continue offering the AstraZeneca vaccine, given that we had these other vaccines that we could offer immediately that didn't have this side effect of concern. So for people who haven't had the vaccine yet, they can get one of the mRNA vaccines. There are some people out there who got a first dose of AstraZeneca and they're wondering about their second dose. We are waiting on some further information about what that's going to look like. There are a couple of really promising opportunities, and it might be the case that people are able to get a second dose of that vaccine, or they might be able to get a dose of a different vaccine, depending on what some of the evidence and some of the clinical trials and studies are going to show us.
Perfect, thank you. Deputy Mayor Anderson, I see you have your hand raised.
Thank you. Thank you, Dr. Tenenbaum and Dr. Khenti for doing this. This is very important, obviously, for our community to hear from professionals. Oftentimes, there is a knowledge war that we are battling with respect to rumors and facts, and it was important for DCCBA to provide this platform where facts could be provided. So with that being said, and I do appreciate the contextual information with respect to sort of how vaccines are overall, and then being more micro with respect to how it impacts individuals from marginalized groups. So kudos to both of you for that. So I have two quick questions. One is today, or sometime this afternoon, I heard Dr. Tenenbaum, you talked about sort of the goal to reach at least 75% of the population. I've been hearing between 70 and 75. There are some doctors that are coming out and suggesting that needle, no pun intended, has sort of moved to about 80% because of the variants. Now, of course, the goal is to get everybody vaccinated, but is that where we're now going because of the variants, where the goal is now 80%? So that's question number one. And I'll let you address that, and then I'll go to question number two.
Sure, thank you, Deputy Mayor Anderson. It's a great question, and it's one that we've gotten before. The short answer is yes. With the new variants, given they can pass from person to person more easily, our goals need to be higher. I don't know exactly what the number is based upon the variants. We've asked our Public Health Ontario partners, the scientific experts, to try and give some input into that. And we're waiting on some clarification about what the number is. But we want to go to 75% and beyond, and we're really not going to stop until we're able to get as close to 100% as possible. I should also mention that when I talk about 75%, that's a really rough measure of the coverage across our community, but that in some ways papers over some real variation. And we know that even if we hit 75% or 80% overall, we can have pockets where maybe we have 90%, and other pockets where we have 50%, 60%. And so as we get to a higher level overall in our community, we're going to be scrutinizing where do we have pockets of people who are not as well vaccinated, and be more focused to make sure that we get a more consistent coverage to protect everyone in our community.
Okay, and my second question is either for Dr. Tenenbaum.
Before you ask the second question, the only thing I would add to that point is the higher risk you are as a community, perhaps because you're involved in essential work or you're a frontline provider, then the higher the bar. It should, so if you talk about 75%, if you're really high risk community, you should be looking at 80 to 85%.
Yeah, well said. And it's encouraging to see on television these pop-up clinics in these marginalized areas where there are a number of people who are lining up to get the vaccine. So hopefully we'll reach that target. But my last question is, with respect to the second dose, I know that there's the research is sort of preliminary on this, but by way of second dose, the question is whether if I got the Pfizer shot the first time, should I be waiting for the second Pfizer shot, or is it okay to get Moderna or AstraZeneca for that second shot?
That's a really good question. And that's one thing that I think the science in the coming weeks will help clarify for us. There are some really good studies going on in Britain that are looking at mixing and matching vaccines and how that impacts the effectiveness of the vaccines. I think for people who got Pfizer, they should have no problem getting a second dose of Pfizer. Same thing for Moderna. So it should be really easy to get a second dose of whatever vaccine you got if you got those two. For AstraZeneca, it might be a little bit trickier, and that's where we're going to look more to the recommendations coming from these studies.
Thank you.
Awesome, thank you. I'll go to our second pre-submitted question. There are comments circulating online that the vaccine causes sterilization. Do we know what the long-term effects of these vaccines are, or is it too soon?
Right.
So I can, why don't you go ahead, Dr. Khenti?
Is that really, the point of sterilization actually, you know, there's several vaccines have come with baggage, so to speak, because of, you know, who was doing the vaccinating, and also because of the racism that was involved in some of the vaccinators. I mean, like, you know, from starting with polio back in the 1920s. So the idea has been circulating on WhatsApp that this vaccine is going to affect the fertility of the African population, the sub-Saharan African population, as well as the Black population of the world. But there is absolutely no evidence that it's even feasible, given the science of both types of vaccines, that this would be achievable, much less that it would be a goal for either pharmaceutical companies or any particular government in this time. But because of some of the histories of vaccination drives, and actually it used to be the reverse, denying people of African descent access to vaccines using some myths about the diseases. But you know, it's one of the things that we confront right head on, to say there's no scientific basis for that idea.
Perfect. I'm glad you tackled it head on, because, you know, there are lots of conspiracy theories going around and miseducation that is significantly impacting the community. So it is critical that we get the right answers, the facts, and that's why the experts are here. So thank you for that. Dr. Tenenbaum, did you want to add additional commentary as well?
I think Dr. Khenti covered it very well, better than I could. I think
Perfect.
The key point is there's no reason to be concerned about that.
Excellent, thank you. We do have a few more questions in the chat. I think I just answered it. There's a lot of conspiracy theories out there involving Bill Gates and others that is being done to enable population control. Your comment. So I think Dr. Khenti, you just effectively answered that question. The other question that is in the chat: as more vaccines come in, will our health units move up the time in between doses earlier than 4 months?
Sure, so I'm happy to take that one. And the short answer is that's probably going to be yes for most people. When we started the vaccine effort in January for our community, in December for the province of Ontario, we had a very, very, very little supply of vaccine. There's a lot of challenge with manufacturing, and we had very, very few doses. And in public health, we had to think about how to make the biggest impact from that small number of vaccine doses. And we decided, based upon the recommendation of scientists and experts, that it made more sense to give more people 1 dose than to give a smaller number of people 2 doses. That means more people can benefit, they can reach more people in our community. And because 1 dose is still quite effective, at least in the short term, it means you get more people with some degree of protection. And that was the judgment call that public health experts made back in that context. Right now, we're in a place where we're getting many, many more doses. The supply of vaccines is much better. We're getting 10,000 or more doses of the Pfizer vaccine a week in our community, for example. So we're going to be able to rapidly not just offer more people first doses, but catch up and give second doses to people, even if a full 4 months hasn't passed.
Perfect. In terms of how effective the vaccines are against the variants, do we have any stats around that as yet?
So we do have some stats, and it's something where we're constantly learning as more studies are done. Of course, the variants are really important in Ontario right now. Most cases of COVID-19 are caused by one of the variants. And the most important variant is we call it the B117 variant, the variant that came from the UK. and that is overtaking all the other variants. It is the vast majority of all of our cases in Ontario. What we know, quite fortunately, is that all the vaccines we have been using are very effective against that variant, that B117 UK variant. There are some other variants out there that are either already existing or that might emerge down the road. And we always worry about the possibility that some of these variants might, be able to escape some of the vaccine protection. It's something we think about a lot, and it's something we pay very close attention to in the science. And so we might, for example, have concerns about needing to give boosters down the road to make sure people have coverage against those variants if that's an issue. Right now, though, we do have really good protection against the most important variant with all the vaccines that we're using.
Perfect, thank you. You're just answering all my questions on the list. This is amazing, thank you. I guess one of the other important questions that was pre-submitted, who is responsible for collecting data when it comes to the vaccine, for example, on race? And I know Dr. Khenti touched on the fact that Ontario has been sporadic in collecting race-based data. How can we, drive that mission forward so that we ensure that we're collecting effective race-based data and to be able to inform studies for the future?
That's a huge challenge, but we know that Health Canada, the Public Health Agency of Canada, and there's a CAFIS, which has a very complicated name, collects all the data on adverse events and uses more traditional demographics. I don't think race is one of the demographics that they capture, but I stand to be corrected on that. But we've been advocating in Ontario successfully, I think, to find out who's not taking. We want race data, not necessarily for adverse effects, because we don't expect racially defined adverse effects. 9% of the people in the clinical trials were of African descent, which is huge in terms of clinical trials for vaccines, or even for any of the traditional medicines like aspirin and Tylenol. We don't normally reach a threshold which is similar to the level in the population in a clinical trial for vaccines. So this was highly unusual for these vaccines to have such a stellar representation of people of African descent. And so we don't necessarily expect racialized responses in adverse effects. However, what we want is to know who is getting the vaccine and who is not getting the vaccine, so that we can target our public health messaging and our public health efforts and actually go to the doors of those who don't and getting the vaccine to find out why they're not getting the vaccine. Is it because of transportation? Is it because they don't know how to register, they don't have computer access? Or is it because they need to hear from someone about the affairs around the vaccine? So it's a very different reason. It's an equity reason for collecting the data. Ironically, anyway, I don't want to take up the time with the whole genetic, why we don't have a lot to worry about when it comes to race and side effects for the particular vaccines. Okay,
perfect. We do have a follow-up question in the chat from, for someone who has had the AstraZeneca as their first shot, what will they get as their second shot? And with all of this negative publicity about the AstraZeneca, and if they are to receive another one, is it safe to do so?
Sure, I can take a stab at that. So there's going to be probably two different possibilities for someone who got a first dose of AstraZeneca in terms of their second dose. The first possibility is people might get a second dose of the same vaccine, the AstraZeneca vaccine. We know that, of course, we're concerned about this blood clotting risk, but it seems like that is a risk that goes down substantially when you get a second dose. It seems like for whatever reason, people who are likely to get that reaction are much more likely to get it during their first dose. And we're looking at data from the United Kingdom to better understand exactly what that risk is. Right now, it seems like it could be a 1 in a million kind of risk, but we're trying to better understand that. The second possibility is you might be able to offer people a dose of a different vaccine, an mRNA vaccine like Moderna or Pfizer for their second dose. There are some studies going on right now to look at whether that's going to produce the same kind of effective immune response. I suspect that it will, but I'm looking towards the studies to make sure we have a good handle on that. But there's probably going to be a couple of good options out there once people have the time come up for their second dose.
Okay. Another AstraZeneca question. If you've had your first dose, but for medical reason you can't have your second dose, does that mean that you are unprotected?
So without getting into too much of the specifics about why someone wouldn't be able to get a second dose, I can say that what we know about the first dose of a vaccine is it gives really good protection once you get it. And within a couple of weeks of getting it, you begin having some pretty good response in terms of your risk going down for having COVID-19, your risk for becoming sick, your risk for passing it on to others. All of those things seem to go down after one dose. We don't know as much about how long that protection lasts. We think that after getting a second dose, it's going to give you a longer lasting protection. And it's probably also going to bring that good protection up to be very good or excellent protection. So there's a couple of good reasons to get a second dose if you've had a first dose. Depending on someone's individual, medical history and what their doctor or care provider is recommending, might be a good reason for them to delay a second dose. But I would say for someone in that position, it's probably best for them to talk with their care provider about what makes sense for them. Perfect,
thank you. Deputy Mayor Anderson?
Yes, this is for Dr. Khenti. Vaccine hesitancy is real. Even in my own household, my mother was very reluctant to take the vaccine because of what she was hearing from other friends, church members, and some of the dribbles on the news. When she was provided all the evidence, she then went and took the vaccine and then became a vaccine champion herself, thankfully. But Dr. Khenti, what I'm curious is, you've worked and done a tremendous amount of work in Toronto in dealing with the hesitancy, and particularly in marginalizing the Black community. How are you finding your message sort of resonating with the people who you're speaking to? And has the information that you've been able to provide some level of reassurance for the community?
I could have given you that question to ask me. Yeah, because no. The first point is, when we deal with people who are vaccine, the only reason we still use the term vaccine hesitancy is because it's defined by the WHO. It's a global term. It's to allow for comparison across countries. But for people of African descent, it's really not about vaccine hesitancy. It's about vaccine mistrust. And the reason they mistrust the vaccine has less to do with vaccines than it does to do with pharmaceutical companies, their experiences with medical institutions, and their experiences with government. And in the past few years, they've had a lot of reasons not to trust any of them. And I could drill down further in terms of the proportion of people of African descent who report past year discrimination in public spaces, especially healthcare settings, which lead them to think and be very suspicious. And that's especially the case for health professionals. So it's not just people who are at the receiving end of a health interaction in a clinic, it's people who actually work in such settings who are very skeptical. So one of the very surprising things that we've been dealing with is a significant level of hesitancy amongst nurses, PSWs. You would think every PSW would be rushing out to get vaccinated, but you'd be surprised to find out that in all of the many long-term care situations, the highest hesitancy rate is among Black PSWs who have a lot of questions about the institution and about the way they're treated. So what we do, first of all, is really respect the position of people who have these levels of mistrust, and we don't try to change their minds. We say, you know what, we understand that there are very valid reasons why anyone of African descent living in North America would be hesitant, given what we know of Johnson & Johnson's behavior around talcum powder, for instance, or Pfizer in Africa, where they went with their meningitis vaccine and tested it with children because of the regulatory framework that was lacking in West Africa at the time. So there's reason to be hesitant. There's reason not to trust. And we're not here to create trust or build trust. We're just here to help you weigh the risk of COVID versus the risk of the vaccine. And it's when you compare those risks, you realize we're looking at an elephant and an ant in terms of risk, because the elephant really is COVID. COVID, like I said, is 35 per 100,000, and it doesn't stay at 35 if you got asthma or if you got diabetes or if you got high blood pressure. Your risk actually increase, and once you get to the hospital, it shoots up. So the job is to stay out of the hospital, and that's what the vaccine does. But getting COVID and being in a situation, being an essential worker, being a healthcare professional, being a nursing aide, and being a PSW, and by the way, tomorrow is PSW day, the risks are too huge. And, you know, we respect the listener. We don't try to change their minds. We don't argue. We just provide the evidence and say, take your time, weigh the risk, make your own decision. And I'm telling you, my mom had a vaccine appointment. She canceled. She lives in Ajax. She's 80 years old. She has a heart disease, high blood pressure, poor lung capacity, and she canceled it because she said she was afraid of a blood clot. She wasn't going to get the Astrozenica vaccine. She was going to get the Pfizer vaccine. But she didn't tell me. I said, Mom, I mean, like, I found out a month after she canceled the appointment. I said, did you have any after effects of the vaccine? She said, no, I didn't take the vaccine. I didn't want to get a blood clot. People in the church told her she would get a blood clot. So I said, Mom, you see me on TV, you always call me to say, I saw you on TV. What, you know, you look good. What happened? You're trimming your mustache. So what's... I said, but Mom, you're not paying attention to what I'm saying about vaccines. So, you know, attitudes and beliefs are very hard to change, even people that you trust. So if people don't accept your information, you just got to respect them and say, I appreciate the fact why you wouldn't, but you need to be informed so that if the worst thing should happen, you need to know you made the decision based upon all the evidence. And that's all you can do, is make sure they have all the evidence to weigh the risk.
Mm-hmm.
Just before you go with the next question, Alethia, I see that Mayor Sandy Brown, I believe, has joined. I don't know if Mayor Brown, you want to say hello to the folks, or you have a question you may want to raise yourself?
Well, I certainly love to say hello. I'm trying to absorb everything. So, Steve, I don't have an immediate question right now, but I'm glad to be here and glad to learn about you know, the concerns. I'm listening to Dr. and understanding some of the concerns that people have, and that we have to respect everybody's opinion on taking the vaccine, but try to encourage them. The science appears to be there. It's helping everybody, and we already see the numbers dropping. I want to thank Dr. Tenenbaum as well for all the good work he's been doing for Wellington, Dufferin, you know, the Guelph public health. So some of the concerns that people have, that we have to respect everybody's opinion on taking. Try to encourage them. The science appears to be there. I see that everything's trending in a really positive direction, and I just would like to encourage everybody to get out and get the vaccine. We know those over the age of 18 can now get it as of today, and that's all really positive news. So that's all I wanted to say, Steve. I really thank you for calling on me, but it's interesting to be here. I'm very learning and appreciate putting this together. I know Alethia and you put this together. It's very good. Everything's trending in a really positive. I just would like to encourage everybody to get out and get the.
Okay, thank you, Mayor Brown. So, yeah, go ahead.
Thank you, Mayor Brown. We have two more questions. I know, Jordan, you have a question, and then Sim will turn to you next.
Awesome, thank you so much. This could be for both Dr. Tenenbaum and for Dr. Khenti, but during the presentation, I noticed that the efficacy rates shown were based on 14 days after the first shot and then 21 days after receiving the second dose. I'm just wondering if there's any updated data on the efficacy rates now that the second doses have been pushed to as far as 4 months after receiving the first dose, and how, I guess, how close are those efficacy rates to, I guess, to the original numbers that were presented to the public?
I'm happy to take an answer to that. It's a good question, given that we have been delaying the interval between doses, and that, you know, these clinical trials are done based upon having 3 or 4 weeks, for example, between doses, whereas we're going up to 4 months. What we've learned is that after that first dose, you begin developing that protection 2 weeks out. And then it seems that the more time has passed after your first dose, the more and more protection you still get as your immune system learns and builds its response. And then when you get the second dose, it really boosts that up and further builds upon the protection you already had from dose number 1. There is some emerging science, some studies that are going on that are looking at whether, in fact, delaying the second dose beyond what the original clinical studies did actually gives you better protection, gives you higher levels of antibodies in your blood, for example, compared to people who followed a shorter interval. It's something that we did it because we thought it would serve the population overall best, but now that it has been done in Canada, it has been done in the UK and other places, we're beginning to learn about how it might actually have been a better approach because it gives your body more time to build that response to the first dose before dose number 2 is given to you. So I don't have exact numbers to give you, and those numbers in the slide are based upon the clinical trials, but some of the science that's happening right now is looking at that question, and so far it sounds like it's quite optimistic.
That's perfect. Thank you so much.
Perfect. And Sim, you have a question?
Hi, thank you, Dr. Khenti and Dr. Tenenbaum. I just have a question in terms of vaccine hesitancy. I'm finding a lot of friends and family in the community are very comfortable with the concept of a brand new vaccine for the senior population and adults in general. But how would you advise parents who do have some level of vaccine hesitancy in regards to weighing the pros and cons of their risk of COVID versus a new vaccine in the context of how to parent and decisions and making that around giving it to your kids? Thank you.
I'm happy to take a pass at that unless you'd like to go first, Dr. Khenti.
Go ahead.
Okay, so I think that's a great question, and we know that people are willing to tolerate different kinds of risks when it comes to themselves or it comes to an adult compared to when it comes to a child. We know that when it comes to other vaccines, some parents have questions or they need more information about the safety of getting a measles vaccine or a flu vaccine. And that's something we're quite familiar with in public health. What we talk about is all the safeguards that are in place before a vaccine is offered to a child to make sure that we know it's safe. So as I mentioned, initially when the vaccine studies are done, it's done in adults, and then gradually there are follow-up studies, more studies that look at how to safely give that vaccine or some version of that vaccine to younger age groups. Right now, I know that Pfizer, Moderna, and Astrozeneca are all doing different clinical trials looking at giving a version of their vaccine to children to make sure that it's safe and to make sure that's effective. We have every reason to believe that it would be effective, but the trials are there to make sure that we have confidence before we begin offering it to those youngest age groups, to make sure that we can inspire confidence in the children and their parents, and to make sure that we have a good system in place. One thing, this is still a new vaccine. Given that we rolled this out initially in adults, and given that, of course, we're in a pandemic, this vaccine's been rolled out at a rapid clip around the world, we're now at a place where we've delivered millions upon millions upon millions of doses over the past 6 months globally. And we've delivered many more doses per week or per month than we would do with most vaccines. So we're learning very much rapidly. We're gathering a lot of data quite rapidly on this vaccine compared to our usual vaccines. And so far, all that data is really reassuring. And it gives me reason to believe that we're likely to see these vaccines approved for kids. Maybe it's going to be a different version with a different amount of the product in the vaccine dose. But I think that these vaccines so far have really performed well. And I expect the trials that are going to be done to allow us confidence that we can give it to children safely.
The only thing I would add to that is that if your child has a condition such as diabetes or asthma or heart disease, then you really need to think about the vaccine for children, as above and beyond waiting for the vaccines for the clinical trials to reach their conclusion, because the risk may outweigh the benefits of waiting.
Okay, perfect.
Thank you.
We are almost at time, but we have a few more questions. If you've had your first dose and you are missing your menstrual cycle, what is the reason for this? And have you received any other cases where individuals have missed their menstrual cycle as a result?
So I know there has been some information circulating about a theory that the vaccine can impact your menstrual cycle. What I can tell you is that that's not something that we're seeing when we get the reports of any side effects. It's not something we saw in any of the studies or the trials that were done for the vaccines. And based upon how the vaccines work, it wouldn't really make sense for it to impact your menstrual cycle. It's working in a way that is very different than the way your menstrual cycle works. For someone who has missed their period or it's come late, we always think about other reasons that might have happened. Of course, if someone is concerned, they should go talk to their doctor, think about whether they could be pregnant, for example, as the most common thing. But that would be something that I would not think of the vaccine causing.
Okay, great. Thank you. Alethia, I believe you have a question. I see your hand up. If you're talking, you're on mute. Okay, guess not. Are there any other questions from the audience before we let these amazing doctors go for the night? I hear silence and I see no action in the chat. So
Mayor,
before—
Mayor has a question.
Okay.
Sorry,
And Alethia is back.
sorry, I was.
Sorry, Alethia, go first, and then Mayor Sandy Brown.
Sorry about that. Thank you, guys. Alethia, you asked my question. I couldn't put my hand down though, and I couldn't see.
Okay, no worries.
Thank you.
Mayor Sandy Brown.
Yeah, just thank you, Alethia. So doctors, I just was wondering if you could give us the prognostication on when we're going to be at, say 90% vaccinated in Canada. Is there any, now that the vaccine seems to be flowing, is there any projections, and where are we going to be in, say, 2 months from now?
Oh, that's a big question. It's tough to say. I think that in terms of the available vaccine supply, we're getting lots of it in right now. So if everyone wanted a vaccine and was really enthusiastic to go out and get it, we could probably get everyone a vaccine dose before the fall or into the early fall, if things keep up in terms of the supplies continuing to get in. One thing we know, though, and we're expecting in public health, is that as we get that number higher and higher in terms of people who've gotten their vaccine, people who are left are going to be some people who are harder to reach. Maybe because they're skeptical, maybe because they don't have the physical access, maybe they can't get the time off from work to get their vaccine, maybe they have other barriers. And as we get further and further and closer to our goal, we're all going to have to work harder and harder to try and reach those people who haven't had the vaccine yet. It's going to be a lot of work. It's going to happen over a long time period. And so we might see a slowing down of our rate of success, but we're expecting that. And that's going to be a lot of work for us that we are needing to be doing in the future.
The good news is that the recent efforts in Toronto shows that when you go to people with disabilities, you go to people who are racialized, who are living in socially isolated circumstances, they come out to get the vaccine. You knock on their door, we're here to give you a vaccine. They'll come down, we're in the lobby. Why don't you come downstairs and get your first dose? And they'll be vaccine hesitant up to the time they sit in the chair talking to the doctor or the nurse. But you just got to say, yeah, you're protecting yourself, you're protecting your family, you're doing this for the wider community at large, and it's all good. And so, I'm very optimistic that early in 2022, we probably will hit that 80% threshold. I don't know about 90 or 100%, but we don't need 90 or 100% to be able to go back to a fair degree of normalcy in the way we live our lives. We may never actually stop wearing masks when we're traveling on the bus because of those mutations that are flying around in places like Brazil and India, which can't control COVID as yet. So as long as we have a vaccinated country but an unvaccinated world, we have to maintain our guard against the mutations.
Perfect. Last question, and we'll close it off for the night. Do we end it or foresee the need to have students vaccinated before they re-enter the classroom?
So I know that there's going to be the ability to offer younger people vaccine. I mentioned we began with our older adults, we're moving down towards younger ages. With Pfizer going down to age 12, we're soon going to have enough vaccine that we can offer to people in that age group. The government of Ontario is talking a lot about making sure that we have the ability for students in that age group to get vaccine and hopefully get 2 doses before they go back to school in September. We know that it's incredibly important to have safe schools to make sure people can go to school in person, get all the benefits of in-person learning and feel safe doing that. We might be able to even offer it to younger children down the road once we have some more of those studies come in. But I think that it's something we'll be able to offer. It's a question of when, but we will be able to offer it going forward, I think, in the future.
Yeah. If I could comment, I think it's more important to ring fence the children and make sure that the educators, the administrators, the childcare workers are all vaccinated, because that in and of itself will be a source of protection for the children.
Okay, that's great. Thank you so much. And that brings us to the end of tonight's session. Before we close, if you can take the time, the audience, to take some time to provide your feedback, your commentary in the chat, that would be greatly appreciated. At the end of the night, I will compile all of your feedback and of course share that with Dr. Tenenbaum and Dr. Khenti. And on behalf of the DCCBA executive team, I'd like to thank the Wellington, Dufferin, Guelph Public Health for partnering with us to organize this session. Thank you, Dr. Tenenbaum, for giving of your time graciously. Dr. Khenti, thank you as well for giving of your time to inform and educate our community on this important initiative. It is so critical that we each, take our position and take all of this information that we have learned tonight and make the right decision for our families and for ourselves. So thank you for coming on board to share with us tonight, to inform, to educate, and to get us all safe and healthy in Dufferin County and ultimately Canada. So great job, everyone. Thank you so much and have a good night. And don't forget to tune in on June 1st when we resume our regular Ask the Expert series with Benjamin Law on personal injury law. So stay safe, take care, everyone, and thank you.